Good afternoon, everybody. At the outset, I thank Dr. Mallika for having me here. This course on challenging situations in retinal reattachment surgery, I'll begin by only one line by saying that each surgery of retina vitreous is a challenge. Believe me, the day you become overconfident, okay, this case will be done, it does not work out that way. So, Mallika, each case is very, very challenging in retina. So, I have no financial disclosure related to this presentation. All VR surgeries, I believe, are challenging, and all are different also, especially diabetics and all, they're all different patients. And many patients whom we operate, and as you have gray hairs, in fact, all the patients become VIPs. And patient demands and expectations are so high that they compare it with cataract surgery and they want to join back same day or maybe very fast. They want to join back their duties. Further, consumer courts on your head, because these judges and all, they will not understand. You see, recovery nahi hua. I still remember one patient, PR inaccurate, 660 vision, and they filed a consumer case with Dr. recovery nahi hai iska. So that's what led on to me to make this lecture that there is a struggle. There is a struggle for VR surgeon at very close quarters. And I believe that all surgeries have complications, and all complications are bad, but they do happen. They do happen in the best of hands. Whosoever operates, there are a lot of people who do shadow surgery, that's a different matter, but this complication happens. Anybody who operates, he will have one or two complications sometimes or the other. But also I believe that a surgeon is best known how he handles them rather than avoiding them or creating more and more issues. So that's what I'm going to show here in 2 or 3 videos clubbed into one only. So this is one patient who was around 49 years old. He had detachment, he had uveitis, he had some degree of cataract also. So we started this surgery. It's a 2-plane 23 gauge surgery being done. And we checked the infusion cannula. It was in the vitreous cavity. You see this some broken synechia here, pigment. But you see illumination is not as good. It is looking as if it is coming from the retina. And you see low, I didn't take out that infusion port. A lot of pigmentation, you see the regma component here. Retina is not as mobile as it should be. Then I injected through the active port some PFCL, continued this base dissection with indentation. And then suddenly illumination became further low. And then I took out the upper nasal this thing and put a chandelier there. Suddenly the illumination became very good. And I could manage whatever membranes and PVR which we had. There are a couple of more breaks in the superior part. This active membranes were removed as you do in a usual surgery. And then after the retina became reasonably mobile, we started then the fluid air exchange. And diathermy used to mark all these breaks. One of them was iatrogenic also, and few were pre-existing. Then I removed the PFCL. You notice the retina is becoming balloonous. And at this time, sometimes the cannula may become subretinal. And this is, I think, what happened. Because you see subretinal air coming up in this part. So then again I checked. Not see the tip of the cannula, and this happened intraoperatively. So now he has 1, 2, 3, 4, 5 entries in the pars plana area. Shifted this port. This time the incision was directly vertical, straight, and then removed this air because subretinal air had to be removed. And once it was removed, then we did air fluid exchange. Then the usual thing. Injected silicone oil and lasers, because this patient was a multiple surgery already done. This was the previous surgery scars and all, and then we injected oil and lasered this patient extensively. So the lesson to be learned from here was that infusion cannula to begin with may be normal in position, but at times once the retina becomes balloonous, it may become subretinal, and you have to be prepared for this. And other thing is make your ports directly straight, single plane entry rather than This was another surgery which we are doing. Again, this was a re-surgery. Patient had this PVR, so I took this small pick. It's a bent MVR blade actually, small micro pick, and trying to tease this membrane here. So this was cause of not settlement of retina here. There are 3-4 areas, in fact, of such membrane formation. But this membrane was not yielding and it was tough. And then I took this forceps and we started pulling. But instead of membrane coming out, we created a iatrogenic break here. This membrane was very tough. You see what is happening because the eye is focused on the membrane, but what is happening is there are hemorrhages coming out in the anterior part. And suddenly, oops, what happened was this, although it didn't bleed so heavily because we immediately, after praying for some moments, put PFCL, diathermize that edges of that break, and then with a lot of difficulty, tease that, and actually I converted to bimanual also in this patient because the membrane was tough and I could not have left behind this membrane also. But lesson to be learned here was you have to do the traction test. If the membrane does not come out, use alternate. So I put it in the chandelier and then took scissors and cut out this membrane, which was very, very tough. This was not the end of story. There were multiple membranes in this patient. So this was another membrane here, further anterior. So fortunately for me, I didn't bring in forceps so early. Tried to tease with the help of MVR blade along the, along the curve of the retina. You can see this MVR blade moving along the plane of retina. And once most of the membrane was mobilized with the MVR blade only, then took this forceps and gradually, fortunately, this came out nicely. This is without causing any further break or bleed in this patient. This membrane also was tough, but you have to go to the base again base. Don't catch it with the tip only, otherwise you may have issues again. So this patient, then we injected oil, and this was the end of. This is the last video I am going to show here. This patient had no PVR, but we were doing a VR surgery in this patient, and this patient had actually a problem in the block. You can see this, track from where this. So issue was whether to remove this subretinal hemorrhage or not. So I thought, let me try. We made a retinotomy right over it and removed this subretinal blood, but most of it came, but some parts still remained. Macula was not involved, so I am open to criticism that why touching this? We could have left it alone also. So, but since I had tried and succeeded partly, so I made another retinotomy here, and this time moved it, back and forth and side by side, so that to sever it from the underlying retina, and fortunately this then came out entirely. The entire subretinal blood came out. So I was not wanting to leave this subretinal blood as a post-op period. So I think I'll conclude with this. Just to conclude that no two VR surgeries are same. At times we are confused and in dilemma whether to intervene at the same time or leave it for a second sitting. And any awkward movement may result in disaster and blindness. And there is a constant struggle amongst us at very close quarters. And every VR surgery, as I said, is a fight, and a fight for success. And no one, believe me, can realize the pain or stress of a VR surgeon except a fellow VR colleague. Thank you very much.
Thank you very much, Dr. Lalit. Wonderful presentation. Anyone having any questions?
So, sir, is the lesson that in every case, would you check the infusion cannula tip before you start the case? In every case, as a rule, do you do it, or do you just assume in most cases?
Infusion cannula? Infusion cannula is, I didn't get the question.
Do you always check that the tip is in the vitreous cavity?
100%. Obviously, you see, this has been taught to us, ingrained in our mind, first in, last out, and you have to ensure that it has to be in the vitreous cavity. If you don't see the tip, you can't start.
So if the pupil is small, would you still wait? Would you still?
Yeah. So in those situations when pupil is small, choroid is thick, or it's a balloonous, sometimes if the patient is pseudophakic or aphakic, I may put an AC maintainer for some time. or even in phakic, sometimes I put AC maintainer, or I will take a big needle and do infusion for some time with the help of a, this sharp needle. And once part of the job has been done, and I can visualize the cannula, then I will shift to the infusion cannula.
Otherwise, sir, we can use a 6 mm cannula, the conventional
Yeah,
ones
that's
are
what I
200.
said. Without 6 mm cannula, we don't start because it has to be handy, especially in endophthalmitis patient and uveitis patient, because the choroid is much thicker, and it's a single direct entry which ensures that the tip is inside the vitreous cavity.
How you handle sometime, because at the beginning you can't see cannula, and you are dealing with a phakic eye. Generally what you rightly mentioned, that you put a cannula one side, probably push inside and scratch it from the other side, particularly you are dealing, so with a phakic eye, there always a risk of touching the lens while scratching it out. How you handle that situation?
Touching of the lens by the cannula.
No, touching lens by, because you want to usually go an opposite sclerotomy
Voice
to
is quite
scratch it.
echoing, not able to get actually.
Yeah, what he's saying is if the patient is phakic and if you try to push the cannula to see the tip, then you have a high chance of touching the posterior capsule. So what would you do in that situation?
No, the direction of this thing is because I agree that the lens curvature is such that if you push too much, then you may have that risk. But you put it directly towards the mid-vitreous cavity rather than anteriorly.
Exactly.
Yeah, so the manipulations are so difficult that sometimes there is a temptation to not do all this and create no problems. But it can lead into serious trouble.
You see, one is pre-operatively, one is once you diagnose, first step.
During surgery.
Sometimes intraoperatively,
Yes.
you begin very nicely, but intraoperatively once
As
the
you
retina
had
becomes
the problem,
balloonous,
yes.
or sometimes indentation. If you do indentation in the inferior part, this cannula sometimes may become subretinal also at that time.
Yes.
And because the room is dark at that time, sometimes the assistant jerky movement, that cannula may sometimes get displaced also. So you have to be prepared for that also.
Yeah. Right, so I think time will not allow us more discussion.
Yeah, thank you very much, sir.
Thank you very much, sir. Very good videos.
Thank
Dr. Subhadra Jalali, I think,
Yes,
Professor
yes,
Atul
yeah.
Kumar is not here. Subhadra, you can start.
Do you have any comment?
Sir, how you decide when peeling the membrane, whether you will go bimanual or just you will go continuing peeling membrane with the forceps? How
So
you
this
decide?
story you keep learning every day. You see, by and large, we get away with unimanual only. We may not do an active bimanual in PVR patients, by and large. But you have to do a traction kind of test. You pull, if it is, various directions you pull, loosen the membrane, and do not jump to forceps too much. That if you if you pull too much, your eye should be always on the neighboring retina also. You can't just be focused like, very small field of place. And then if it is not coming, do not keep pulling. Do not keep pulling. You have to mobilize it in such a way. And if it still does not, then you resort to bimanual. This specifically bimanual, we do it in mostly diabetic vitrectomies, where again, similar traction test kind of issue, whether this membrane is taut enough or not.